today we'll be talking about the scalars and basically the waveforms which are seen on the ventilator screen. Last time we had covered about the basics part of mechanical ventilation, and today we'll talk about scalars and the waveforms which are seen on the ventilator. So if you look at this ventilator screen, this is a standard ventilator screen in any of the ventilator, irrespective of the make of the company. What I wanted to emphasize here is if you look at the screen, the 75% of the screen is almost covered by the graphics, and say around 20-25% is covered for the rest of the parameters, the numbers and everything. And if the company people or if the clinicians and the scientists who have given a thought into bringing this thing, so they must have thought a lot of things, and probably that emphasizes the value of this all different graphics which are shown on mechanical ventilator. Unfortunately, what happens is most of the times, maybe because of the way it has been, we focus more on the numbers and we tend to ignore the screen or the waveforms which are seen on the ventilator. But understanding the ventilator waveforms becomes very important, and it gives a very quick and easy diagnosis for most of our problem. So last time when we were talking about ventilator, we talked about how the three important parameters, that is pressure, flow and volume, are there and how they make the basics of mechanical ventilation. Just to re-summarize that thing, there is a pressure generated by the ventilator, it creates a flow of gas, and then ultimately it results in a change of volume in the lung, and that is basically tidal volume. So these three things are represented in the waveform in terms of pressure, flow and volume times scalar. Now before I go for this thing, what do I mean by scalar? We all know there's a x-axis and y-axis, and when we talk about the scalar, this means that the pressure, the flow and the volume, they are represented against the axis of time. That is, it's a continuous beat to beat variation. When I say a loop, this is basically a pressure and flow loop. So there is not a time. There is only one bit which will be seen, but the two parameters across the x and y axis will be pressure and volume or flow and volume. So if there are two parameters, we call them as loop. And if there is a single parameter which is plotted against time, that is something we call as scalar. And there are pressure times scalar, flow times scalar and volume times scalar. Now you will be seeing that in most of the newer anesthesia workstations, the advanced workstations, and even the basics ones which are coming right now, which have an integrated ventilator into them, at least there will be one waveform which will be scalar, and most of them there will be two waveforms. If you look at the advanced ventilators, they will almost have pressure, volume and flow scalars, as well as have loops present into embedded into their screens. So this is the basic difference between scalar and loops. Now, before we talk about individuals, like what are the things which we look into all these three scalars, today I'm going to talk only about the scalars and I'll skip the loop part today. But the most important thing to, before I go for the scalar description, is we need to understand that we need to say no to auto scaling. Now, what do we mean by auto scaling? If you look in most of the ventilators, in most of the ICU setups, many a times you will see that they are on auto scale mode. Now, what do I mean by auto scale mode? What happens is, suppose this is a, imagine this is a pressure scalar, and you have 0 to 60 centimeters of water kept as your scale. It's like a graph, isn't it? It's like a graph, and we have parameters kept here. Now, what will happen is, if you are doing it on a auto scaling, what will happen is, suppose for some reasons this pressures initially were 30 and now the pressures have gone to 50. So what will happen is, with the time, the initially this scale was probably 0 to 30. Now your pressures for some reason has increased. Now the pressures reading are around say 45, and now what will the machine will do is, it will increase the scale back to 60, so that all your waveforms comes looks very nicely in the center of that scale. It is adjusting the scale according to pressures. Now people might say that, okay, this is a very good thing, I am able to continuously see the scale very nicely. But this is a big problem, and this is a big problem especially in resource limited setting. We all agree that in an ICU there should be 1:1 ratio for nursing at least, and doctors also should be in sufficient amount, especially for mechanically ventilated patients. But more often than not, what we see is dearth of shortage in most of the public setups, even at times in private setups, and you will have 3 or 4 nurses managing at times a single patient. Now what will happen is, if you put a somebody on an auto scale, you are not able to actually go to the patient every time. You are seeing from far, and from far you are not able to always make out the numbers, but you are looking at the bigger part of the screen that is covered by the waveforms. Now if it starts auto scaling on its own, you won't realize the problem at times till it is too late. The moment you keep your scales fixed, what happens is, if your pressures are going up, you'll see a change in waveform that my pressures are missing. If you see a change in your flows, you will see your flows are missing. If you see that volume has become suddenly very increased, or it has changed because of the change in lung condition, whatever be the reason, you will suddenly notice that there is a change in the height of the your graph, the scalar graph, and that will alert you immediately. So the most important thing, the first thing when you are setting the ventilator, you set the basic parameters, and then you go to the ventilator setup, where you sort of say no to the auto scaling, and you fix your scales for pressure, flow, and volume. And this is something which should be uniform for the whole ICU. Basically, it should not be like one consultant is doing as per his own this thing, or the other consultant is doing. For that whole unit, your scales should be fixed. Generally, what we do at our place is, we fix the pressure at around 35 centimeters or 40 centimeters, then flow around 150 or 120, generally depending upon which unit we are looking at, and the volumes we are keeping at 500 ml. So now what will happen is, for example, a patient who was nicely being ventilated, for some reason he develops a barotrauma, his pressures have increased and his volumes have dropped. Even if I am far away from the pressure, you will see the alarms are definitely going on, but at the same time you will see what is happening is that your graphs, they are all being like, it is not auto scale, so you'll see that there is not a complete graph. Your pressures will be going very high, and in the same thing you will see that the height of the volume graph has come down, and you will be able to detect problems very early. Second thing is, alarms we set in a very, sometimes it's not a good way to set an alarm, but too many alarms at times becomes a problem. So what everybody will do is, they'll keep the thresholds very high. They'll say, oh, the patient is breathing very high, let me keep the respiratory rate alarm very high, let me keep the peak pressure alarm very high, let me keep the volume alarm very high, otherwise the volume alarms will keep on increasing. So rather, what will happen is, the alarms will also become late. So this visual thing, I'm emphasizing more on this part, is the auto scaling should generally be not be encouraged, at least in a setup where there are resource constraints. This becomes very, very important before we go for the next part. Now we talk about types of waveform in pressure and volume modes. Now if you see, we had last time also discussed, in a volume mode you will have a fixed volume, a fixed pattern of flow, and depending upon your lung compliance, whether your lung is a very nice lung or whether it's a ARDS lung with a poor compliance, your pressures will keep up and down. So a parameter which is fixed will always be shown by a square waveform. So you can see here that this is the flow is waveform is square pattern, and the pressure waveform here is a square pattern in pressure mode. So even if I'm covering the volume mode and pressure mode, and I'm only shown this diagram, I'll be still able to say that, because the pressure mode is a square waveform, this is a pressure control ventilation, and here, because the flow is a square waveform, this is a volume control ventilation. So now let's see these three scalars in detail. So first thing is, we'll talk about pressure time scalar, or simply pressure scalar. Now we have seen already this part. In a volume targeted mode, depending upon the lung, it will change its pattern. So it will be either an accelerating, decelerating, depending upon whatever we are setting. And the flow in the pressure scalar, in a pressure targeted mode, will always be a square waveform. If it was other way around, in a volume control ventilation, the flow would have been a square waveform, and the in a volume control ventilation, you will have the pressure which is varying. Now what are the uses of pressure waveform? At least these are the major uses which we can see in day-to-day use in our ICU and operation theater. We can talk about auto peeping, we can see it very nicely on pressure waveform. We can talk about bronchodilator response, we can talk about active exhalation, breath type, that is pressure versus volume. We can talk about peak inspiratory pressure, P plateau pressure. We talk about asynchrony and trigger effort. Now let's see all of this in slightly different. Now imagine this is a patient and time control. What is happening is, here there is no patient effort. So you can see, if I have set a PEEP of 5, this is a pressure mode and this is a time. So here there was no effort from the patient. So the machine decided that okay, there is no effort from the patient, and I am giving the breath. Now look at this. This is not a square waveform. So what will be the mode of ventilation? This is going to be probably a volume control ventilation. Now here what has happened is the patient has tried to trigger a breath. The moment he's triggering a breath, last time we talked about flow triggering and flow triggering, you will see that there is a dip in the pressure waveform, so you can detect that the patient is also trying to breathe the in particular thing. So you can differentiate from a pressure scalar whether it's a patient generated breath or whether it's a machine generated breath. Now, this is something which all of us should know very nicely. I'll slightly take time on this thing. This is basically a pressure time scalar, how it looks like in a volume controlled ventilation. Now, this is your starting phase. From here, you will have the initial part. The initial pressure is required to overcome the ventilator resist. We have put a HMA, the trachea, and all those things. And then from here, in your trachea to bronchus, and all these things will go. So it is basically reaching the peak pressure. From here, you will have a slight change, and this is where your alveolar pressures or plateau pressures will be represented. So what I want to emphasize again on this thing is, if you look at the pressure scalar, you have an inspiratory time, and after this plateau pressure is coming down, you have an expiratory time like a normal breath. Now another important concept is a peak pressure and a plateau pressure. Peak pressure combines the pressure of all things including plateau also, and that will include your pressure to overcome the resistance of the your airway conducting tubes, if any HME filter is there, if you have put a small tube or all those things. Whereas plateau pressure is something which will be representing your end alveolar pressure, and that is what our targets are generally. I'll talk about this in more detail. Also, if you can see, the starting point is something what we have set. If I have not set a peep, probably my graph will start from 0. If I set a peep of 5 or 6, whatever, depending upon my setting, my flow, I mean my pressure will start from above that peep. So this is very important: inspiration time, expiration time, peak airway pressure, and plateau airway pressure. Now, if you remember last time, we talked about compliance, isn't it? So we'll look into this next slide. What do you mean by static compliance and what do you mean by dynamic compliance? Now imagine this dotted line shows your normal graph. Okay. Now you see, for some reason you are ventilating a patient. He was suppose an ARDS patient, or you have your operation theater a patient, and you see the peak airway pressure has gone up on the ventilator. And then when you see and when you check, your plateau pressure remains more or less same for some reason in this patient. So what you will understand is that your peak pressure has been going up, but your plateau pressure remained the same. Probably the problem most likely is not in the alveolar level, but problem is somewhere in your conducting pathways. Now when I say conducting pathways, it can be not necessarily only a bronchospasm. It can be right from your ventilator end, machine end, to right your till your terminal bronchioles are there. It can be a problem anywhere. It can be a simple bronchospasm, it can be a laryngospasm, there might be some blood clot obstructing the tube, your HME filter might be blocked or something. So it depends. So troubleshooting is a different part. Right now what we are looking at is identifying the problem. So the peak pressure has gone up, but the plateau pressure has remained normal. Probably it is because of the airway resistance. Now look at this another graph. Again the dotted line is showing a normal graph, and now if you look at the peak pressure graph, the peak pressure will go up, but you look at the plateau pressure also has changed from a baseline of say around 15 to a 40. So that means probably the problem is in the alveoli. It can be in a bronchus or something, but because the difference in peak and plateau pressures is less or more or less normal what was here also same thing, isn't it? So the problem most likely is either in the alveoli or the interstitium, because your peak the plateau pressures has gone up. This implies that there is a decrease in compliance of the lung. Now again, this is identification why your compliance can go down, and there can be a number of reasons. Your alveoli are flooded with fluids, ARDS, pulmonary edema, there is interstitial fibrosis, whatever be the reason, isn't it? So you need to identify the difference between a static, that is peak pressure, and the dynamic part, that is the compliance. Now when we talk about the ARDS ventilation strategy, we say that we will allow a P plateau pressures of around 30 centimeters, in obese patients at 35 centimeters. People casually tend to say that we'll allow a pressures of 30 and 35. Those pressures actually imply a plateau pressure and not not a airway pressure. So this is something we need to be very clear about. So this is the important difference between peak pressure and plateau pressure, and it is very easy to do. If you are on a volume control ventilation, especially if your patient is like sedated, paralyzed, you can put a end expiratory hold, and you will be able to see what is happening to this particular patient to see the pressures, I'm sorry, end inspiratory hold. Now the next thing is auto pip. We all talk about auto pip. Like what is happening is auto pip. Auto pip is very simple. There is a pressure which is generated in addition to whatever pip we are giving. That is end expiratory pressure. Most commonly it is because there is already some amount of air which is getting trapped in, and when you are forcing an additional air, that basic air whichever what was trapped in, or your pressure which was there, the pressure is getting added to it. The most common reason is seen in generally in patients where you are not giving enough amount of expiratory time for the exhalation. So what is, suppose a COPD patient, asthma patient, you have kept a respiratory rate of say 14, 15, and you have kept a I time of say 1:2. Patient is having active wheezing. So what will happen is, suppose if I am giving 400 ml of tidal volume, maybe 300 ml is coming in 2 seconds, but now it is taking another 1 or 2 seconds time because we know expiration takes time. But if you are not giving that time, that air will start trapping in, it will start sort of build up pressure, and you will be able to see a peep. So this 5 pip is something which I have said, and now when you can start seeing a next breath, that this auto pip, that is somewhere around 9. So the total pip which is going is almost around 14. So this is something you will see on the numerical scale, and you will see on the graphical scale also. So auto pipping becomes very important. If you I want to emphasize too much on this point, but these are the graphs which you see many times, what we call as the flow starvation graph. So what is happening is, like, probably your patient is hyperventilating, initial septic patient who was intubated recently, isn't it? He is having a high minute volume. Why is he having a high minute volume? This is a common mistake what we do at times. We are having a patient who is breathing at a respiratory rate of 25, 30, having a high minute volume, because his body is generating lot of acid, and that acid will come out by compensatory hypermetabolism. What we do is, the moment we put a tube, we keep our normal setting for this patient, something like what we do in a normal ASA1 patient. We'll keep a respiratory rate of 14, a tidal volume of 400. Now this is not enough for that patient to breathe, and especially if we have sedated and paralyzed the patient, is not able to generate the breath, this becomes a problem again. So flow starvation is something which we need to be very aware about. Even in day to routine breaths, if there is a patient is requiring flow starvation, that means you are not giving enough amount of pressure, enough amount of flow, and you need to increase the flow, and you need to increase your delivery time of that flow. So depending upon your ventilator setting, this is something which can be done. Again, we are not going for troubleshooting as to how to do it, but we are identifying currently on the flow starver. Now rise time, again, not very important, but in some cases yes, it makes a difference. So it is the amount of time it takes to take the desired airway pressure or peak flow rate. Now if you see something graph like this is too straight a graph. So what will happen is, suddenly all of the air is going inside. So this is probably too fast a color. And if you see a long slanting slide, that is probably that the patient is here, you will have a probably a curve, and you will say that the pressure is my ventilator is delivering the flow very slowly. So you need to sort of optimize this thing. Most of the machine will do it on a auto mode. Most of the machines will have a preset value, and generally in most of the cases it will work very well. But we need to be aware about the graph, like whether it is too fast or too slow. Now coming to the second scalar, that is flow time scalar. We talked about pressure time scalar, we'll talk about flow time scalar. Now again, because it's a volume control ventilation, you will have a constant flow. So you will see a square waveform pattern in a flow time scalar mode. And in a pressure mode, what you will see that the flows will keep on changing. I am really emphasizing this thing. In a volume control ventilation, your volume is fixed, your flow is sort of predetermined. So you will have a square wave pattern in your flow. But because your lungs are always in the changing position, your pressures will keep on adjusting up and down depending upon how your lung is. In a pressure control mode, your pressures are fixed, isn't it? So in a pressure control mode, your square waveform will be seen by a pressure scalar. So this is something which we need to be very clear about. Now in a flow time scalar, you will have a positive axis and you will also have a negative axis, generally which is not seen in other things. That in pressure, if you see, it's only mostly a positive wave. If you see in a volume, it's a positive wave. But here In a flow scalar, you will have an inspiration which is conveniently represented by a positive axis, and you will have an expiration which is shown by a negative axis. So only volume targeted ventilation offers a choice in flow waveform pattern as to how do you want, isn't it? In a pressure targeted ventilation, to maintain the constancy of pressure, only the decelerating waveform is used. So this is something, a decelerating waveform which is there. So we need to be very clear about various types of flow waveforms which are seen in this patient. Now, what are the uses of flow time scaler? Again, it can be used to see auto peeping, airway obstruction, bronchodilator response. Again, as we discussed, which is the mode of ventilator, how do you see an inspiratory flow, asynchrony, and triggering effort. So if you see, many of these are overlapping with the pressure time scaler. So we sort of combine all the waveform interpretation together to come to a conclusion as to what is happening to my patient. Again, the same thing, auto pipping will be much better appreciated on a flow scalar rather than on a pressure scalar. So the same thing which I was explaining some time back, you have an inspiration, and now this dotted line shows a normal expiration. Now you see this dotted line is touching here baseline, and you still have some amount of time before your inspiration is starting. That means we have significant time for expiration. All the air which was pushed in the patient's lung is being taken out before the next breath is started. Now, for some reason, imagine that this patient has a COPD and he's having a long expiration time, but we didn't adjust the ventilator. So what will happen is, inspiration is there. Now the patient is taking some amount of time, and it has not touched the baseline. There is still some amount of air. This air trapping will generate an auto peeping, and what you will see is that whenever your flow scalars are not touching the baseline and your new inspiration has started, this is something what will generate an auto peep, which will be seen in the pressure scalar as well as your number, and most importantly, very nicely appreciated on a flow scalar. So as you can all agree and appreciate here. Now, the same patient, imagine that he was having a COPD and everything, and you can see there's a long inspiration time which is required for this patient. Luckily, we adjusted our ventilator nicely. We gave enough expiration time, so we could decrease the auto peep. But we still say that my ventilatory, I'm sorry for the quality of the slide. There is a long expiratory time which is required. So probably there is some amount of COPD or a bronchospasm or something. I gave a bronchodilator to this patient, and what you can see is my peak expiratory flow rate. That is, this is the representation of peak expiratory flow rate has increased, and because this has increased, my expiratory time has become shorter, and that is something helping me, isn't it? My lungs are expanding nicely and rapidly. So you can see to a response of bronchodilator in a flow scalar how it is working out. Now we all set eyes to E ratio and everything, but sometimes the patient has a tendency to breathe either slowly or too fastly. So we'll have to see whether we are setting it in a nice way or not. Now, if you see a pressure control mode, what will happen is, you will see that you will have enough amount of inspiratory end, and then you will be able to see an expiration. I'll come to this particular graph again, pressure support or volume support, as to how we set it, because these are like spontaneous mode. But here you can see that I am having a good amount of inspiratory time, and then I am starting expiration. So I am not hurrying in my inspiration. Then if you see, I am allowing enough amount of expiration time, probably too long, and if my patient needs a rapid breath, I still have the chance, the scope to increase my respiratory rate without creating a worry about whether I will have a auto pipping or not. So this is something we need to understand. Now coming to pressure support and volume support mode. All these modes are control mode. Control mode in the sense that the machine is delivering at a set rate if the patient is not breathing. Pressure support mode or volume support mode is something which is a spontaneous breathing. All I'm breathing is spontaneous, like CPAP, BiPAP, and my pressure, my machine is supporting the ventilator. So how does the machine understand that when I need to cycle from inspiration to expiration? Here it is pretty clear. I set a fixed pressure, I set a fixed amount of time, and after that time is there, my machine will change. But what happens in pressure support? So now let's see what happens in a pressure support or a volume support mode. You can see here I have a trigger flow, and there is something called as inspiratory cycle off. Now we'll see slightly more in detail. You can see here you have a peak pressure, you have a respiratory rate, and of course the FiO2 and everything, and you can see the patient is breathing continuously here. Now let's see what do you mean by inspiratory cycle off. This is very important for all of us to appreciate. When we talk about inspiratory cycle off, what I mean to say is 100% of patient's peak inspiratory flow has reached here. Now at it will start coming down. At what point of coming down, I want to stop my inspiration and convert it into expiration. If you see, this button is something will be adjusting in your pressure support mode, the PS mode, in bigger ventilators, isn't it? And generally it is kept at around 20-25 as a standard, but we need to understand the logic behind it. If you keep at 100%, that means the moment the cycle is the patient has started reached his bed, he will start expiration. This will make the breath very small. And if you keep it say at say late 10%, that means the patient wants to breathe out, but the machine is going to provide inspiratory flow, and this is again going to create a sort of an active exhalation. The work of breathing will increase. So probably we need to decide based on the patient's condition where we want to keep the patient flow, and somewhere around 25 to 30% is most of the time accepted in these cases. So when the funda is again this inspiratory cycle of at what percentage of peak inspiratory flow. So this is something which all of us can be remembering. Now again, I talked about short I time and long I time. Here you can see my inspiration was not completed, but before that only my inspiration started. So I'll need to increase my inspiration time. Now here you can see that I have a lot of inspiratory time. So and probably if I needed, I can probably cut down my inspiration time. So again, this is something which is very nicely being depicted by a flow time scalar. Short inspiratory time, long inspiratory time. Now this is something which is commonly seen. Probably the most of the time the reason is it is because of airway secretions. You will have multiple airway secretion, and you can see a sort of an oscillatory pattern in your flow scalar. So we need to see, especially if we are using not using a HME filter, or if we are using a heated plate, the condensate will come and be accumulated in the circuit. We need to clear and drain it off. Sometimes this might be seen with cardiac oscillations in a thin build patient who is having tachycardia. Now coming to the last part of my presentation, that is volume time scalar. So in a volume time scalar, again you will see it's a positive waveform, and either you can have a mountain peak, or you can have something like a plateau peak. The reason is how much time of inspiration you are giving. If you have given a good amount of inspiration time and there is some amount of inspiratory pause, you will see that there is a plateau in the volume time scalar as well. Now the scalar volume time scalar uses are air trapping, leaks, tidal volume, and asynchrony. Now let's see what again. So this is basically inspiration, and then this is basically expiration. Then again you will have a new breath starting in. So whenever it is starting to coming down, that is the beginning of expiration. Now, this is something we commonly see in our ventilators. See, what is happening is the tidal volume has gone in, inspiration has was there was probably a pause, and then if you see at expiration, suddenly you will see there is a loss. Now, at the same time, if you look into your machine, you will have a two numbers, VTI, VTE, that is tidal volume inspiratory and tidal volume expiratory. Here, what is happening is, for some reason, the tidal volume inspiratory say it was 400 ml, and if you see, look at the VTE, it was 300 ml. Probably there is a curve leak or something, that initially 200 300 ml is coming through the ventilator which is being measured, but then there is a loss of 100 ml from around the space. And what we need to simply do is, the most common reason is your cuff is leaked, and you will need to inflate the cuff properly to a desired pressure, and this should be done ideally in every shift to see that there is no loss of volume. The bigger problem is, if you have a loss of volume, if you have a cuff leak in ARDS patient especially, you will not be able to reach a good oxygenation target, because your airway pressures will not be generated, because there is a leak in the system. Now air trapping, again very important. We talked about auto PEEP in COPD patient, isn't it? In acute asthmatic patient, a young patient, suppose every time I am talking about 400 ml tidal volume, 300 come, 100 remaining. Next breath again I have not corrected it, so the air is keeping on accumulating. So what will have is, your lung volumes you see will start increasing. So this is actually a medical emergency. If you see your lung volume going so high, it's almost creating a condition like tension pneumothorax. Rather than in pleura, your lungs are expanding so much that it is creating a very positive intrathoracic pressure. It will decrease your cardiac output. It might cause bradycardia, and if not corrected, it will cause asystole. This happens very commonly in asthmaticus patient, acute status asthmaticus patient who are intubated and whose ventilatory setting has not been done. So what you need to do is, you need to change your inspiratory expiratory time. But before that, you simply need to disconnect the ventilator, let the air which was collected inside that auto PEEP needs to be released, and then connect the ventilator with the proper setting. This can be a life-threatening emergency if not corrected in time.